Increasing IOP is a key risk factor in glaucoma progression. IOP fluctuates over the course of a day, with elevated levels at night. And IOP is still the only modifiable factor in glaucoma treatment. But is just a strong IOP reduction enough? Studies show greater IOP fluctuation may increase visual field progression. Quality-based IOP control may be more effective than just quantity-based reduction. Tafloprost has the power to control IOP through day and night with a greater nighttime IOP reduction. Behold, Tafloprost brings you the power of quality IOP control.
Namamaga at masakit na talukap? Kumonsulta na. Maaaring nakararanas ka ng impeksyon sa paligid ng mata na tinatawag na preseptal cellulitis. Ang mga karaniwang sanhi ng preseptal cellulitis ay mula sa sugat o kagat ng insekto. Ang kuliti o hordeolum na mukhang tigyawat sa paligid ng pilik mata ay maaari ring magdulot ng preseptal cellulitis kung kumalat ang impeksyon. Ilan sa mga sanhi nito ay paglalagay ng makeup sa mata at paggamit ng maruming contact lens. Maaari rin itong epekto ng pagkalat ng impeksyon tulad ng sinusitis o impeksyon ng sinus at otitis media o impeksyon sa tenga. Ang mga sintomas ng preseptal cellulitis ay pamumula at pamamaga ng talukap ng mata. Maaari rin itong maging masakit at may kasamang lagnat. Agarang kumonsulta para mabigyan ng gamot at maiwasan ang pagkakaroon ng komplikasyon. Ano nga ba ang dapat bantayan pagdating sa preseptal cellulitis? Tandaan na kapag lumala ang pamamaga ng mata, lumabo ang paningin, at masakit kapag ginagalaw ang mata, ito ay tanda na ang impeksyon ay kumalat na mula sa talukap hanggang sa mismong mata at maaari itong mangailangan ng operasyon. Kapag nakaramdam ng kahit anuman sa mga sintomas na nabanggit, mainam na kumonsulta agad sa iyong doktor. Maaari bang maiwasan ang preseptal cellulitis? Oo. Ugaliin ang tamang paghuhugas ng kamay para makaiwas sa impeksyon na galing sa mikrobyo. Iwasan ding hawakan o kamutin ang sugat o kagat ng insekto sa talukap ng mata. Upang iwasan ang ibang impeksyon na maaaring magdulot ng preseptal cellulitis, ugaliin ding maghugas ng mukha, lalo na kung gumagamit ng makeup, at siguraduhin malinis ang contact lens bago ito gamitin.
Increasing IOP is a key risk factor in glaucoma progression. IOP fluctuates over the course of a day, with elevated levels at night. And IOP is still the only modifiable factor in glaucoma treatment. But is just a strong IOP reduction enough? Studies show greater IOP fluctuation may increase visual field progression. Quality-based IOP control may be more effective than just quantity-based reduction. Tafloprost has the power to control IOP through day and night with a greater nighttime IOP reduction. Behold, Tafloprost brings you the power of quality IOP control.
Namamaga at masakit na talukap? Kumonsulta na. Maaaring nakararanas ka ng impeksyon sa paligid ng mata na tinatawag na preseptal cellulitis. Ang mga karaniwang sanhi ng preseptal cellulitis ay mula sa sugat o kagat ng insekto. Ang kuliti o hordeolum na mukhang tigyawat sa paligid ng tilik mata ay maaari ring magdulot ng preseptal cellulitis kung kumalat ang impeksyon. Ilan sa mga sanhi nito ay paglalagay ng makeup sa mata at paggamit ng maruming contact lens. Maaari rin itong epekto ng pagkalat ng impeksyon tulad ng sinusitis o impeksyon ng sinus at otitis media o impeksyon sa tenga. Ang mga sintomas ng preseptal cellulitis ay pamumula at pamamaga ng talukap ng mata. Maaari rin itong maging masakit at may kasamang lagnat. Agarang kumonsulta para mabigyan ng gamot at maiwasan ang pagkakaroon ng komplikasyon. Ano nga ba ang dapat bantayan pagdating sa preseptal cellulitis? Tandaan na kapag lumala ang pamamaga ng mata, lumabo ang paningin, at masakit kapag ginagalaw ang mata, ito ay tanda na ang impeksyon ay kumalat na mula sa talukap hanggang sa mismong mata at maaari itong mangailangan ng operasyon. Kapag nakaramdam ng kahit anuman sa mga sintomas na nabanggit, mainam na kumonsulta agad sa iyong doktor. Maaari bang maiwasan ang preseptal cellulitis? Oo, ugaliin ang tamang paghuhugas ng kamay para makaiwas sa impeksyon na galing sa mikrobyo. Iwasan ding hawakan o kamutin ang sugat o kagat ng insekto sa talukap ng mata. Upang iwasan ang ibang impeksyon na maaaring magdulot ng preseptal cellulitis, ugaliin ding maghugas ng mukha, lalo na kung gumagamit ng makeup, at siguraduhing malinis ang contact lens bago ito gamitin.
Increasing IOP is a key risk factor in glaucoma progression. IOP fluctuates over the course of a day, with elevated levels at night. IOP is still the only modifiable factor in glaucoma treatment. But is just a strong IOP reduction enough? Studies show greater IOP fluctuation may increase visual field progression. Quality-based IOP control may be more effective than just quantity-based reduction. Tefloprost has the power to control IOP through day and night with a greater nighttime IOP reduction. Behold, Tefloprost brings you the power of quality IOP control. Increasing IOP is a key risk factor in glaucoma progression. IOP fluctuates over the course of a day, with elevated levels at night. And IOP is still the only modifiable factor in glaucoma treatment. But is just a strong IOP reduction enough? Studies show greater IOP fluctuation may increase visual field progression. Quality-based IOP control may be more effective than just quantity-based reduction. Tefloprost has the power to control IOP through day and night with a greater nighttime IOP reduction. Behold, Tefloprost brings you the power of quality IOP control.
Good afternoon, everyone. Welcome back to TMC EyeTV. For our followers, 5 p.m. on a Thursday afternoon only means one thing. It's time once again for another episode of TMC EyeTV, Ophthalmic Construction Without Borders. I am Rainier Covar, and I am hosting this afternoon's show. With me is my good friend, Dr. Mike Munoz. Mike?
Thanks, Rain. It's really surreal thinking about how this little project has come a long way. And would you believe we have done successfully 12 episodes to date? This project, however, would not be successful without our subscribers, our speakers, and our industry partners. So, to begin this afternoon's show, we will listen to some words from our sponsor, Santen. To give opening remarks is Mr. Humberto Las Pinas, the head of sales for
Greetings to all ophthalmologists tuned in for this afternoon's event. Our deepest gratitude to the esteemed organizers, headed by the Director of the Medical City Eye and Vision Institute, Dr. Victor Caparas. It is our privilege to be the industry partner to bring episode 12 of the Medical City EyeTV webinar series. This pandemic has totally changed the landscape on how we do continuing medical development. The Medical City EyeTV webinar series is a good platform wherein it cultivates the wealth of knowledge and shares it across the ophthalmology community. Santen strongly supports this initiative to ultimately benefit the patient and to give them the best vision experience. At Santen, true to our new slogan, Imagine Your Happiness, we will be at the forefront to be social innovator in the ophthalmology industry, and we will take a proactive lead toward better eye condition. Thank you.
Thank you, Mr. Las Piñas. Although medications truly help us ophthalmologists in managing our patients' eye problems, chronic or excessive use of these have significant effects on the condition of the eye. This is the main issue that we will be tackling today. We have invited experts from the fields of cornea, external diseases, dry eye, and most importantly, glaucoma, to share their knowledge as well as their experiences in dealing with these cases.
That's right. So we have three speakers lined up for today, and to be followed by some case presentations later on in the show. I hope our viewers are as excited as we are because this topic is very practical issue, and it's not only for specialists but also for general ophthalmologists. So, Rains, please tell us who do we have today?
Our first speaker is none other than our Institute Director and the mind behind the conceptualization of this learning platform, Dr. Victor Caparaz. Dr. Vic, our big boss here at the Medical City, is also the head of the Cornea and External Disease section. He obtained his medical degree at the University of the Philippines College of Medicine and subsequently took his ophthalmology residency at the Philippine General Hospital, where he was also the chief resident. Dr. Vic did this cornea fellowship at the Skepens Eye Research Institute at Harvard Medical School in Boston. He is the founder and past president of the Philippine Cornea Society.
Indeed, Dr. Vic is really truly our idol. Now, let's go to our second speaker, Dr. Mary Ellen C. She will talk about some alternatives that are relatively safer without compromising patient goals. Ellen is the treasurer for the Philippine Academy of Ophthalmology. She is a graduate of St. Louis University for her medical training and at the Department of Ophthalmology and Visual Sciences at the PGH for her ophthalmology residency. She pursued further training in cornea and external disease at the same institution and trained for cataract and refractive surgery at the American Eye Center as well as Jules Stein Eye Institute in the USA. Presently, Ellen is an active consultant at the TMC Eye and Vision Institute and the American Eye Center.
To end the first part of our show, we have Dr. Marimel Veloso. She is not new to EyeTV, and we are very glad that she has agreed once again to do this episode with us. Dr. Veloso is a glaucoma specialist who trained at Harvard Medical School in Boston. Prior to that, she completed her medical school and ophthalmology residency at the University of the Philippines College of Medicine and at the Philippine General Hospital. At present, she is the co-director of the glaucoma service at Asian Eye Institute and also my other boss, as she is the vice chair of the Department of Ophthalmology and chief of the glaucoma service at Rizal Medical Center.
What an awesome lineup, Rainier. Your questions, don't forget to type them in the comment section as we will address them at the end of all the lectures. So let us not wait any longer and welcome our first speaker as he gives us an introduction to one of the most commonly used preservatives and how it has been considered an enemy, especially on the corneal surface. We now give the floor to the one and only director of the Eye and Vision Institute, Dr. Victor Caparas.
Thanks for tuning in. Thanks for tuning in. Just like our host said, this is something of great value, but often overlooked. Now, with the advance of science, more and more drugs are coming out that are good for our patients, that help us treat our patients. And eye drops are the most common medications that we give. In fact, they are the tools of our trade. With improved understanding of diseases, we have a large selection of eye drops today, and in some cases, replacing surgery. In fact, the global eye drop market in 2017 was valued at $15.5 billion, dollars, and it's projected to grow until 2025 at a rate of almost 5% a year. And it's projected to be more than 22 billion in 2025. Among those that are growing at a faster rate than the others are the dry eye products and the glaucoma products, which together will be worth more than $15 billion dollars in a short time. So what's the point of all of this? Well, take for example this Korean study from 2017. It looked at 1,050 glaucoma patients with a mean age of 55.1 years. They had mild glaucoma, more than half of them, and about 43% of them were on a single eye drop medication, a PGA eye drop alone. Okay, so let's do some calculations. If the mean age at diagnosis of this study was 55.1 years, and the average lifespan of a Korean person is 82.3 years, by the end of their life, they would have applied more than 10,000 drops of the PGA. Now, that's just the PGA. That's not counting lubricants, anesthetics, dilators, antibiotics, steroids, if ever they have a disease or some surgery. So you can imagine the amount of drops that have gone into that person's eye. So, what's the point of all this? What are the implications for our patients? Let me show you this old study, and it was done by the group of Christophe Baudouin from Paris, who has devoted his life to studying ocular surface disease, specifically the effects of preservatives on the ocular surface. He did a cross-sectional survey of more than 4,000 patients. These are glaucoma patients as well. And cross-sectional means some of them were newly diagnosed, some have been long diagnosed, and he found that 84% used preserved eye drops, 13% non-preserved, and 3% used both types. So what did he find? He found that patients complained of discomfort almost 2 times as much, or more than 2 times as much as those who were using non-preserved. So let me say that again. Those who were using preserved drops were more than twice as much as those who were using non-preserved. And they were complaining of burning and stinging, foreign body sensation, feeling of dryness, and eyelid itching. They also noticed that the prevalence of these symptoms were dependent on how often they were putting it and for how long they were putting it. So, there lies the rub, as Shakespeare said. You know, we give eye drops and medicines in the effort to treat our patients, to make them feel better, to treat their disease. However, we also overlook that in that eye drop that we prescribe, there are other components there that are not necessarily good for our patients, where we probably know it, or sometimes we overlook it, or we are not aware of it. And this is what I call the hidden enemy. These are the preservatives that are in the bottle, but not necessarily talked about or discussed whenever the products are presented to us. So I looked at our formulary and I found out that 93 plus percent of all the multi-dose eye drops available to us contain a potentially damaging preservative. If you don't believe me, let me show you. Of all the antibiotics, these are all the antibiotics we use mostly, 4 out of the 6 popular ones have BAK, which is the most popular preservative. The other 2 are non-preserved, and they are like that because their antimicrobial properties allow them to be in the bottle unpreserved. Of all the corticosteroids, all 4 that we use have BAK. Of the lubricants, ironically, the drops that we give whenever we have a patient with ocular surface disease, many of the popular ones have BAK, and even those who don't have BAK have a form of preservative which may or may not be as deleterious to the ocular surface. Of the glaucoma drugs, the carbonic anhydrase inhibitors, we only have 2. They both have BAK. Of the adrenergics, all have. There is one version that has a different type of preservative. Of the PGAs, 3 out of the 4 that we use have BAK. The other has a preservative which is in the same class as BAK. And of the very popular combination drugs, again, you have BAK predominating. So, what is BAK? BAK is short for benzalkonium chloride. The Brits call it BAC, but we'll use the BAK which we're used to. What is it? It's a chemical class called quaternary ammonium. And if you see that blue globe in the center of the head there, that's the nitrogen. And what it does is that it acts on the surface of, let's say, a cell membrane and reduces the surface tension. And that's why they sometimes call it a surfactant. And that effect causes emulsification of the lipid. And that's why it's also sometimes referred to as a detergent. So what does that do? Well, the business end of BAK is actually in the tail, at the end of the carbon chain, which is hydrophobic. And I'll show you in a few minutes why that is. The effect of this is that it disrupts intermolecular interactions, causes the dissociation of the cell membrane bilayer, and disrupts even the intracellular membranes. So the sum effect of that is that it compromises the permeability of the cell, and it causes the leakage of the cellular contents into the external environment. Okay. Before we go into the mechanism, let me say a few words about the human cell membrane or the mammalian cell membrane, as well as the bacterial cell membrane. It's actually composed of a bilayer of phospholipids oriented tail to tail. And what that structure does, is it imparts on the membrane a hydrophobicity, meaning to say it repels water. Because one of the most important functions of a cell membrane is to separate the internal environment from the external environment, which is mostly aqueous. So you can see here a nice animation of it. Also, on the surface are calcium and the magnesium ions, which serve to stabilize the membrane. Now, what happens when BA comes in, as you can see from those tadpole-like structures there. The BAK, with their tail leading first, enters actually, because it's a very small or low molecular weight molecule, is able to insinuate into the membrane and causes a disruption of the intermolecular interactions. What happens also is that the magnesium and calcium ions are freed, causing instability of the membrane and eventually dissociation and disruption of the membrane. So that's a nice setup for this brief video that I want to show you. So here is the BAK molecule, and when it's dropped into the eye, as you see, this is the epithelial surface of the conjunctiva. It can be as well for the cornea. You see the microvilli, and this is a close-up of the membrane, and the BAK molecule disrupting the membrane through its hydrophobic tail. So once in there, and you're talking about millions of these molecules, the effect is to disrupt the membrane, disrupt the internal environment, and cause the eventual rupture of the cell, causing discomation of the surface. Now, one thing that you notice from this video is that when the cell is ruptured, it actually releases the BAK that has entered the cell. And that will explain, as you will see later, why it's dose dependent and cumulative. Okay, so what is our evidence? So that was a nice video, nice graphics. What is the actual evidence of toxicity? Okay, so a very nice set of experiments run by Leong et al. Showed and looked at human corneal epithelium and stained them, did some immunofluorescence staining for several indicators for cell viability. The first one that they looked at was apoptosis. What is apoptosis? Apoptosis is the programmed cell death, meaning to say that as we get older, our cells are programmed to die off at a natural rate, just like when the cornea sheds its epithelium every 7 to 10 days. That's apoptosis. What happens when it's exposed to some toxic substance, apoptosis is accelerated. So here's what they did. They stained human corneal epithelium with the necessary stain to fluoresce, and they subjected these tissues to certain samples. The control was the PBS, phosphate buffered solution, and tafloprost, which have no preservative. It was preservative-free. So if it's stained for an apoptotic cell, it's stained green, as you might see there on top. And then they subjected it to other drugs. These are all PGAs, some containing BAC, and they actually expose it to just BAC or BAK alone. And if you can see, with the tafloprost, there are some apoptotic cells, but if you compare it to the PGAs with BAK, you can see that there's significantly higher number of cells stained. What they did too was wait 24 hours for the epithelium to recover, and then they stained it again. And as you can see, there's almost the apoptotic cells are there. In fact, in many cases, there are more, especially in the higher concentrations of BAK, especially where the red arrow is pointing with a BAK concentration of 0.02, whether it was combined with latanoprost or it was just plain BAK. Another marker is for inflammation, and here they stain for CD54, which is a very common inflammatory marker. And the same substances were used. So again, with PBS, after 24 hours, they looked at the concentrate. They looked at the epithelial sample, and they looked. They subjected it to the other samples as well. And what did they see? Well, um, with PBS and preservative-free tafloprost, you can see that there is some amount of inflammation happening. But if you look at bimatoprost with even a very slight concentration of BAK or a BAK concentration of 0.01, you can see that almost the whole sample, epithelial sample, fluoresces. You can see less of it with these other epithelial samples, and the explanation of that will be the BAK actually already eroded all these cells so that there are no cells to fluoresce. The next marker was for cell proliferation. And again, if there is a proliferating cell, it stains green. And as you can see with PBS, again, because epithelial cells do proliferate, you can see some staining there at 24 hours and even after 48 hours. You can see also that the basal layer is very highly fluorescent. And that makes sense because that's the layer where the cells actually come from. So you can expect a very high degree of activity happening there. Okay, as you can see from my arrows here. Now, look at the ones subjected to BAK and the BGAs. You can see that for bimatoprost and for travoprost and BAK alone, you have a high degree of cell proliferation. And although you can see after 48 hours a little bit after bimatoprost and BAK, the rest you no longer see very much. Again, it's the same explanation. The preservative destroyed the cell, and so there are no cells that can be stained. Finally, they looked at the cell junctions, and they stained for the proteins that represent the cell junction. So it's slightly different here, and what you look for are those fine lines, and basically they represent the junction between cells. As you can see, with PBS and preservative-free PGA, the cell junctions are preserved, they stain very nicely. If you look at those subjected to the PGAs with BAC, only with bimatoprost with BAK can you see some slight remnants of the junctions, not very well defined as compared to the non-preserved samples. And with the rest, you see nothing. So no cells, no cell junctions survive the exposure to the preservative. Another study now showed how BAK affects the innervation of the cornea, which was not always recognized before. We thought that the prime effect was on the epithelial cell. However, this study clearly shows how it affects the density of the corneal nerves. And as you can see, on the left are the untreated patients on the top here. Okay, so you can see a very nice network of nerves, very well. On the right side, the fluorescence, that's the pattern, basically no fluorescence in the cornea. And even on day 7, there is no change. Compare that to the BAK exposed corneas, and you can see almost immediately, if you compare it with the untreated corneas, a lowering of the density. There is some staining on the bifluorescence, but the effect is much more clear when you look at day 7. So you can see a real decrease in density of the corneal nerves with both concentrations of DAK 0.01 and 0.1. And that is also paralleled by increased staining, which means that you probably had some cell dropout, and that's why the cornea stains with fluorescein. If you want to look at how it goes down, so after exposure, there is a drastic decrease in density, and then after that, it slowly regenerates. But mind you, it's not a full regeneration, and not all of the nerves will actually be able to return. So I said a while ago that damage is dose dependent and cumulative. Okay. At a very low concentration of 0.0001, we have already been able to demonstrate arrest of growth. And if you increase that concentration to zero point 0.01, you already get increased apoptosis. And if you further increase that concentration of DAK, you get cell death. So 0.1 is a little bit high for the the normal commercial concentration of DAK in our eye drops, but definitely you can see that it's between growth arrest and apoptosis where most of the concentrations of our commercial products will land. In fact, damage begins at a concentration of 0.005. The longer the exposure to DAK, the increased, the more you have epithelial cell lysis, and the more chances you'll have permanent change, as you saw in the previous video. So, what are the repercussions on the ocular surface? Well, if you can't see it from the video already, let me spell it out for you. There are direct cellular effects on the corneal and conjunctival epithelium. So it actually kills the cells. The epithelial microvilli are destroyed. The intercellular glycopeptides, the interaction between the cells, are dissolved. And as a result, the epithelial layers are desquamated. So you have cell dropout. Again, as a result, the tear film becomes unstable. And that's due to the detergent effect because you disrupted the lipid layer of the tears. And you also, because of the corneal denervation, you disrupted the very important lacrimal feedback system. Okay. And as well, as you saw in the previous experiments, there are inflammatory and immunoallergic reactions, which has some repercussions on the treatment that you will give later on, especially if this is a glaucoma patient. So, what is the clinical evidence on actual humans? We have seen that ocular surface disease is very prevalent in patients who have glaucoma, who are using anti-glaucoma eye drops. So in this study, they looked at the OSDI rating, the ocular surface disease index. And they found 51% were normal, 21% had mild OSD, 13% had moderate, and 13% had severe. This is from a sample size of 630 glaucoma patients. So you can see here that almost 50% of all these glaucoma patients have OSD, whether mild, moderate, or severe. And more tellingly, more than 1 out of 4 have moderate to severe OSD. We also noticed that these signs of intolerance increase with the number of eye drops that they were using, eye drops with preservative. If these patients were not using eye drops, they naturally had about 37% who had some of these symptoms. Maybe they had pre-existing dry eye. Um, 26% will have some signs in the conjunctiva, and a small proportion with lid signs and signs of dry eye, which is punctate keratitis. Once you start then on eye drops, it is a big leap. There is a very significant increase in symptoms and signs. And this pattern proceeds as you increase the number of eye drops used. This is another study that will drive home this point. Another study looked again at a population of glaucoma patients. Those who were still had no meds had 5% with dry eye, as measured by punctate keratitis, which is actually a more advanced sign of dry eye. When you started them on one medication, the prevalence or the incidence doubled, more than doubled. But look, when you added a second anti-glaucoma drop, it more than tripled, almost 4 times as much, as many patients were now complaining of dry eye. And if you added a third med, it's increased, but only very slightly. So, so it's also true that from one med to two meds and from one med to three meds doesn't make much of a difference. The damage or the problems already start when you add a second drop. Finally, BAK causes inflammatory changes in the conjunctiva. Okay, so this is the group of Badouin, and they again looked at patients. What they did now was look at conjunctival samples after glaucoma medication use. So if they had no previous use, hardly anybody showed fibroblastic infiltration, which is a sign of inflammation. If there was one medication being used for about a year, the number greatly increased. And when you looked at their conjunctiva, 63% of these patients had inflammatory cells infiltrating the conjunctiva. And if they had more than one medication, 92% of all the patients, of all the conjunctival samples showed inflammatory cells. Again, these are clinical proof of how BAK causes inflammation and damages the epithelium. So, why use preservatives at all? Well, obviously, we have to protect the sterility in the bottle, so it provides a level of antimicrobial activity. It limits bacterial, amoebic, and mycotic infections. It maintains the sterility over the course of multiple uses. These are multiple use drugs. And it prolongs the half-life of the drug. So some of the bacteria or the microbes can cause degradation of the active component, and putting in a preservative will make sure that these active ingredients continue to work as indicated. Now, it's not always up to the scientists and doctors to decide, as we have found with this COVID pandemic. It's probably even harder to convince regulatory agencies and legislation to change their requirements about preservatives in multi-dose products, because this is actually in the law. In the US, it's in the FDA. And also, on the business end of it, by changing the formulation or repackaging these products, it will take a lot of money and a lot of investment, many of which, the primary investments of which of these new drugs probably haven't been recouped. So, in summary, I've shown that preservatives in eye drops do cause damage to the ocular surface. And it's not as if we're ignoring it, because there are attempts to try to mitigate the OST. They're trying to decrease the concentration of the preservative. They're trying to use alternative compounds, and they're trying to do away with the preservative altogether. And this is the topic of a very interesting talk by Dr. C following me. However, at this point, there is no current ideal solution. And the best I can say is that we are all responsible to be aware of the precautions to take to minimize the damage. While we cannot control these drugs, while we may not have a choice, at the very least, we must be aware of the hidden damage that can be done when we give these drops that we use. Thank you so much.
Good afternoon. After that very extensive discussion of Dr. Caparaz on BAK, I will now be presenting the softer preservatives and preservative-free options. I have no financial interest in any of the medications in this presentation. Most of the ophthalmic topical preparations are mostly supplied in multi-dose containers, and inadvertent touching of the dropper tip to any part of the eye can cause contamination. Preservatives are needed to inhibit or destroy microorganisms, but along with it, it also prolongs the shelf life and prevents decomposition of the active drug. However, the mechanism of the preservatives to kill the microorganisms can also be toxic to the cornea, conjunctiva, and tear film, causing dry eye, and chronic ocular surface inflammation can also cause subconjunctival fibrosis. That's why preservatives are called a necessary evil. Preservatives can be classified into three types, but the two major types are detergent preservative and oxidative preservatives. The detergent preservatives, as mentioned by Dr. Caparaz, destroy the cell membrane, causing all the cytoplasmic contents to come out and become lysed, while oxidative preservatives penetrate the cell membranes through the production of free radicals, and then they interfere with lipid, DNA, and protein metabolism of the organism. The ionic buffered preservative also acts as an oxidant. Methylconium chloride has been in the market since the 1940s and is in most of our ophthalmic preparations. But because of the toxic effects, manufacturers have tried to find better preservatives for our eye drops. So alternatives to BAK include softer preservatives and also preservative-free systems. So the alternative preservatives are less toxic to the eye surface, but may still cause toxicity when used frequently. And then there are less clinical studies on these preservatives and are not as widely available as BAK. Here's a summary of the 5 common alternative preservatives to BAK. We have polyquaternium-1 or polyquad, stabilized oxychlorocomplex or purite, sodium perborate or aqua, borate sorbitol, propylene glycol, and zinc or Sofcia, and chlorhexidine. The first 3 are oxidative preservatives. Sofcia is an ionic buffer, while chlorhexidine is a detergent. Let us go to each preservative in detail. So polyquaternium-1 or polyquad is actually related to BAK. It is a quaternary ammonium compound. However, because of its large size, it does not enter the mammalian cells. exerts its oxidative function through a positive charge that acts on the cell membranes of microorganisms to disrupt their metabolism. However, higher concentrations of polyquad can reduce conjunctival goblet cells, decreasing mucin, and frequent dosing can also cause dendritic keratopathy. Examples are the cysteine family of products. Stabilized oxychlorocomplex or purite is a mixture of chlorite, chlorine dioxide. It also is oxidative and it disrupts the protein synthesis of the organism. It is called a gentle preservative because it dissociates into sodium, chloride, water, and oxygen upon installation on the eye. However, it can also be a mild irritant. Examples are Optiv, Optifusion, and alpha-GAN-P. Sodium perborate or Gen aqua converts into hydrogen peroxide when combined with water to exert its antimicrobial activity. It is called a soft preservative because it decomposes to water and oxygen when exposed to catalase and other enzymes in the conjunctiva. However, also with higher concentrations, it might cause ocular stinging and is a direct in vitro mutagen. Example is Gentil. Borate, sorbitol, and propylene glycol and zinc or SOFSIA is an ionic buffered system that is not significantly toxic to the ocular surface. It also dissociates into harmless elements upon installation. It has lower toxicity versus BAK and causes mild irritation, but unfortunately, Trabitan Z is not available in the Philippines. Last is chlorhexidine gluconate. It is an antiseptic with a topical antibacterial activity. The positively charged molecule reacts with the cell membrane, penetrating the cell and causing leakage of the intracellular components. It causes less cytotoxicity and less corneal barrier disruption compared to BAK. We also use 0.04% eye drops of chlorhexidine for acanthamoeba keratitis. Example is Tiquas. Now we go to the preservative-free systems. The ABAC system is called ABAC because it is free from BAK. The ABAC system has a membrane which filters 0.2 microns in size and produces calibrated and reproducible drops of 30 microliters. So the filter can filter both the eye drop coming out and any contaminants coming into the bottle. It is safe to use up to 8 weeks from opening. Examples are Hayabac and Timabac. This is another illustration of the ABAC system. The commode system is a pump system with 2 valves. The first valve is in the upper portion or the piston, and the lower valve is a silver ball. So these 2 valves tightly seal the bottle and prevent the entry of microorganisms, and also the medication does not come in contact with the surrounding air. It is safe to use up to 6 months after opening. Examples are Hylocomod and Hylogel. Next is an ophthalmic squeeze dispenser technology platform. This platform uses a tip seal technology with a tip seal and a venting filter. It dispenses 25 microliter drops and can be used up to 3 months after opening. Example is Catunorm. So when you squeeze the bottle, the tip seal opens and the drop is dispensed. After you release the bottle, air goes through a filter before entering the bottle. So we go to the self-preserve or self-sterilizing products. Moxifloxacin and levofloxacin are called self-preserved. Because they pass the antimicrobial preservative efficacy test of the US Pharmacopoeia. They are adequately preserved without the need for BAK. They are effective against staph, Pseudomonas, E. coli, Candida, Aspergillus, and moxifloxacin is also effective against Nocardia, Fusarium, and Acanthamoeba. The unit dose preservative-free vials are ideal for frequent instillation of eye drops. Frequent instillation means more than 6 times a day. So it's also ideal for patients on multiple medications and those who have ocular surface disease. However, unit dose preservative-free vials are a bit expensive and difficult to use for the elderly and those who have arthritis. They have a 12-hour shelf life once opened and may contribute to single-use plastic waste. So this is a table showing the common anti-glaucoma medications available in the market. So as you can see, only Travatan and Alphagan P are preserved with the softer preservatives. Lumigan and Taflotan, Lumigan PF and Taflotan S do not contain preservatives. Travatan Z and Timoptic XE are not available in the market. Timoptic XE is preserved by benzododecinium bromide. For the anti-glaucoma combinations, most of them are preserved by BAK, except for Duotrav, Ganfort PF, and Tapcom S. As you can see, our dry eye drops are also preserved with BAK, but more of the softer preservatives can be seen in our artificial tear preparations. And they also have the preservative-free options. Most of our antibiotics and steroids are also preserved by BAK, except for levofloxacin, moxifloxacin, and the moxifloxacin plus dexamethasone combination. All our other eye drops are also preserved by BAK, except for cyclosporin and Acuvale. So as you can see, as discussed by Dr. Caparas, preservatives exert an ocular surface damage. So they do this by hypersensitivity or allergic reactions, alteration of the tear film causing dry eye, and direct epithelial damage with chronic or cumulative use. There have been reports of dendritiform keratopathy with frequent use of preserved artificial tear preparations. But our eye drops are not only composed of the preservative. We also have the active drug, the drug delivery system, viscosity increasing agents, buffers, stabilizers, and the vehicle. So let us not forget that the active drug itself can also cause toxicity. So we have our notorious agents which can cause toxic keratoconjunctivitis. We have the anti-glaucoma medications like the alpha-2 adrenergic agonists, the PGA, CAI, and pilocarpine. We have the aminoglycosides, proparacaine, atropine, and ketorolac and nepafenac, or NSAIDs, have been reported to cause corneal melt. These are some examples of the toxic effect of preservatives on the eye, of the active drug on the eye. So we can see follicular conjunctivitis with the use of trifluridine, an antiviral, bulbar conjunctivitis secondary to acroclonidine, an anti-glaucoma preparation, and toxic ulcerative keratitis secondary to proparacaine abuse. Both the active drug and the preservative can cause pseudopemphigoid, causing shortening of the inferior conjunctival fornix and symblepharon formation. Ciprofloxacin can also cause corneal deposition. However, all these effects are reversible once you, with the cessation of the causative agent. In summary, BAK is the most common used preservative in most ophthalmic topical preparations and can be safe in the usual concentrations and low-frequency dosages. But we should opt to shift to alternative-free preservatives and prefer preservative-free options for chronic glaucoma patients on multiple medications, dry eye patients needing frequent dosing, and those with ocular surface disease. In the future, we hope to shift all our patients to preservative-free eye drops, and maybe there will be cheaper and easier to use options. So these are my references. I would like to thank Christina Tan, our Cornea Fellow, and the TMC EyeTV production team. Thank you and good evening.
Good evening. It's an honor and pleasure to be back once again. And I'd like to thank Santen and the Medical City Eye and Vision Institute for this opportunity. Intraocular pressure is the only known modifiable risk factor for glaucoma progression, and its reduction remains the cornerstone of glaucoma treatment. In the glaucoma landmark studies, the risk of glaucoma development in an ocular hypertensive was reduced by 50% at 5 years when treatment is started. And in early glaucoma, for every 1 millimeter mercury reduction in pressure, the risk of progression was minimized by 10%. When we talk about quantity of pressure control, there are key concepts to keep in mind, and the first is target pressure. Defined as the pressure level below which further glaucomatous damage is unlikely to occur, target pressure actually decreases chair time with your patient because it's easier for the patient to understand a more concrete goal when there is a set number to work for. Calculators, formulas, tables have all been created in the past to help us determine target pressure. Setting target pressure, however, is based on a combination of significant risk factors in each patient. And it is not set in stone because flexibility will not be factored in, and sometimes rigidly adhering to target pressure may cause more harm than good. This is why the preferred target pressure in our clinical practice should be individualized, dynamic, reset as needed, and modified based upon the balance between the risk and benefits of each particular therapeutic step we intend to take. The corneal effect is the second concept, and central corneal thickness took the spotlight when ocular hypertensives with thin corneas had a significantly higher risk of developing glaucoma. In a meta-analysis done by Doughty, the normal central corneal thickness was set at 534 microns. Knowing that thicker corneas give us higher pressure estimates and thinner corneas lower pressure estimates, how do we now correct for pressure on the basis of central corneal thickness? In the same meta-analysis, a correction of 2.5 millimeters mercury for each 50 microns change in corneal thickness was proposed. The group of Ehlers even came up with a correction table, giving the equivalent of pressure based on corneal thickness. However, up to this point in time, there is no valid correction factor. The implication that pressure can be corrected with a linear correction factor is an oversimplification of what is a complex nonlinear relationship between corneal thickness and true pressure. Keep in mind that biomechanical properties like corneal hysteresis that measures viscosity and elasticity of the cornea can also affect pressure readings. Now, without a correction factor, how useful is central corneal thickness in our clinical practice? Central corneal thickness still serves as an important guide in determining glaucoma risk. Remember that it is a confirmed predictive factor for conversion of an ocular hypertensive to glaucoma. And in my practice, if it's a major outlier, more than 600 or less than 500 microns, then the significance in adjusting target pressure may be justified. Response rate is the third concept and is defined as the proportion of patients showing an adequate response to treatment. A clinical relevant response to medication is a decrease of 20% or more from baseline. And we know that there are differences in response rate between classes of medications. But even within the same class, prostaglandins that have shown similar mean pressure reduction have varying patient responses. And in a study done in mostly ocular hypertensives and open-angle glaucoma comparing bimatoprost to latanoprost, a significantly higher response rate was observed for the bimatoprost group. And in a normal tension glaucoma study, the tafloprost group showed a significantly higher response rate than the travoprost group. So why the difference in response rates? And this has been attributed to the varying pharmacological structures of prostaglandin analogs that result in difference in corneal permeability, drug metabolism, and affinity for receptors. So given the difference in response rate between classes and within the same class, response rates are important consideration in our clinical practice. Follow-up remains crucial, so the decision to stay, switch, or add can be done in a timely manner. Switching within the same prostaglandin class may also be justified, time permitting. And keep in mind that response rate over time is equally important. So we should watch out for drug desensitization or tachyphylaxis. Now, fluctuation of the pressure is the fourth concept, and this can be classified as into instantaneous after blinking or rubbing the eyes, 24-hour, short-term, which is from days to weeks, and long-term from months to years. So our focus will be on the 24-hour and long-term fluctuation and its effect on glaucoma progression. Now, when we do a phasing during the waking hours, the usual trend will be the pressures will be highest in the morning, later dropping towards the afternoon and evening. However, in a 24-hour phasing conducted in untreated glaucoma patients taken every 3 hours in their habitual positions, where the pressures were taken in the sitting position from 9 a.m. to 9 p.m. and in the supine position from 12 midnight to 6 a.m., the results showed that most of the peak 24-hour pressure values occurred between 12 midnight and 6 a.m., which is definitely out of office hours. So given that office phasing at present has problems, if we do office monitoring, the pressure may not be monitored during the nocturnal period. And if we do an inpatient 24-hour monitoring, nocturnal pressures may be measured, but they may not be in the sleep cycle or the supine position if the appropriate tonometers are not available. So given that office phasing may not reflect the true 24-hour pressure curve, is diurnal office monitoring still useful in clinical practice? And the answer to this is still yes, because it still gives us more than a single snapshot of pressures within the day. More pressure measures can help us determine why certain patients progress at apparently controlled pressures in office visits. And it can also help us determine whether an ocular hypertensive should be observed or treated based on the respective pressure spikes. Now, long-term fluctuation, on the other hand, can be expressed as a range or standard deviation over a period of time. And in the AGES and SIGIT study, it was a confirmed strong predictor of visual field progression. And in a study by Hong as well, where he stratified long-term fluctuation into a standard deviation of less than 2 and greater than 2 millimeters mercury in patients with primary angle closure and open angle glaucoma after undergoing a combined cataract and glaucoma surgery. The results showed that patients with lower pressure fluctuation showed better visual field preservation. On the contrary, however, in the EMGT and OAT study, no influence of pressure fluctuation was observed on visual field progression. So why the conflicting results? And this may be due to differences in methods and study population use, because in the EMGT and OATs, the patient's pressures were at a higher level since most of them were subjected to either observation or topical medications, while in the AGES and SIGITs, the patients had significantly lower pressure levels since a significant number of them underwent glaucoma surgeries. Experts actually believe that the results from the landmark glaucoma studies are complementary rather than contradictory. Greater long-term fluctuation may be damaging in eyes with low mean pressures, but it becomes less important when the mean pressure is higher, because higher pressures may tend to offset the effect of fluctuation on visual field progression. So despite the study differences, fluctuation remains a factor worth considering in glaucoma management. And given its importance, together with emphasis on regular and timely follow-up, do we now prescribe self or home monitoring of pressures in glaucoma patients? Currently, we have few tonometers of this kind available. One would be the contact lens sensor, exemplified by triggerfish. It consists of a contact lens that comes with an orbital antenna and sends signals to a recorder. It is capable of continuous 24-hour monitoring in the habitual position and the wake-sleep cycle. Although it does not provide an absolute value of pressure, it provides relative changes or variations in pressures within a 24-hour period based on changes in the limbal corneal circumference. There is fair tolerability, although a number of patients still complain of blurring and discomfort while on the contact lens. A simpler device is the home version of the eye care tonometer. Although it records pressure slightly lower than the Goldman, it still fairly correlates with it. There is no need for an anesthetic or fluorescein dye. It has to be held horizontally, and because of an automatic eye recognition system, pressure monitoring is easier. This model cannot measure pressure in the supine position, and second-party monitoring and self-monitoring is possible, but self-monitoring may be difficult in elderly patients. Now, although still in the early testing phase, the smartphone tonometer has been developed, and this actually consists of a smartphone attached to an applanation device, and in the supine position, after putting anesthetic and fluorescein, the applanation is recorded by the video from the smartphone. So pilot studies so far show good correlation with the Goldman. So it's something to watch out for in the future. So given this current pandemic, self or home tonometers may be a consideration. I wouldn't really discourage patients that would want to purchase one, but we should also know that there are limitations with these current tonometers, since more improvements are still needed in these devices. And the search is still on for the ideal self-monitoring tonometer. Now, quantity is an essential part of pressure control, but intraocular pressure is not just a numbers game. We need to consider pressure from various perspectives in order to reach quantity and quality of pressure control. And by identifying and solving problems with medical treatment, we can reach quality pressure control. When we have a patient that comes with well-controlled pressures of 12, but and visual fields and scans that are stable but presents this way, this is not a happy patient, and this is not quality pressure control. This is actually a case of ocular allergy, which is the first problem with medical treatment. Allergy can either be from the active ingredient or the preservative, and allergic reactions usually present with contact dermatitis and allergic conjunctivitis. Closely related to ocular allergy is your ocular surface disease, or OSD. Nearly 60% of patients report symptoms of ocular surface disease in at least one eye. And there are different types of preservatives that have already been discussed. And BAK, or benzalkonium chloride, is still the most common preservative found in glaucoma medications. And BAK has multiple toxic effects on the tear film, cornea, conjunctiva, and can damage trabecular meshwork cells. In a study in patients where topical medications for glaucoma were started, the incidence of blepharitis and dry eye, uncommon before glaucoma treatment, more than doubled in number after the start of treatment, especially in patients taking multiple topical medications. Now, adherence and persistence is the third problem. And among the medication-related barriers to adherence, difficulty with medication schedule ranked the highest, and this was followed closely in second place by difficulty with drop administration and side effects of medications. It has been shown that patients with side effects had a higher level of non-adherence, and those on preservative-free medications had a lower rate of self-reported non-adherence. Now, increased failure rate of glaucoma surgery is the fourth problem with medical treatment. And in the preservative exposure and surgical outcome, or PESO study, the time to surgical failure was shorter in patients receiving higher preoperative daily doses of BAK compared to patients with lower BAK exposure. And based on clinical and experimental study, Baudin said it best when he concluded that As preoperative inflammation underlies postoperative fibrosis, the management of ocular surface changes should be the new paradigm in glaucoma care. And the first step is prevention, removing the compounds responsible for inflammation. So we've seen that most of the problems with glaucoma treatment are preservative related, but preservatives do have their advantages in providing stability, increased drug penetration, and antimicrobial activity. Shifting to preservative-free will definitely improve safety and tolerability. But what about efficacy? And when BAK preserved medications were compared to their preservative-free versions, there was no difference in the amount and duration of pressure reduction. In a one-year prospective crossover study comparing preservative-free tafluprost with BAK-preserved tafluprost in primary open-angle glaucoma and normal tension glaucoma patients, no significant difference in mean pressure reduction was observed between the two groups. Now, for safety and tolerability, on the other hand, as expected, after switching from preserved latanoprost to preservative-free tafluprost, there was a significant reduction in the signs and symptoms of ocular surface disease and an improvement in the tear film breakup time and tear production after 12 weeks. So given the superior safety profile of preservative-free medications, do we now consider preservative-free for all patients? And this brings us to the question of who will benefit the most from preservative-free. We can actually divide these patients into two groups. Treatment-naive patients that will benefit from starting preservative-free from the onset, and patients already on medical treatment will benefit from switching. So for the first group, treatment-naive patients that can start preservative-free, this will include newly diagnosed patients with pre-existing ocular surface disease. Keep in mind that ocular surface disease may be present even before we start glaucoma treatment. So the question to ask at this point is, do we check all patients for ocular surface disease before starting glaucoma treatment? This would actually be ideal. If asymptomatic, I try to do a routine screening. No real extras here after putting the anesthetic and fluorescein before pressure check. I try to check for tear breakup time, cornea and conjunctival staining, as well as quickly scan the lids for any signs of blepharitis or Meibomian gland dysfunction. If symptomatic, however, or has ocular surface disease signs, a more thorough check will have to be done or co-management with the EV cornea specialist. Now, the elderly will be the next group because of the increased risk of ocular surface disease, which is further worsened by eyelid laxity and conjunctival chalasis. Women in their menopause years further increase and compound this already existing problem in the elderly. Now, because of prolonged exposure to toxicity of medications from an extended life expectancy, young patients, which include pediatric to young adults, will benefit from preservative-free early on. Fourth would also be patients in certain work and leisure environments like those in air-conditioned, low humidity, desiccated atmospheres, which will include your in-flight cabin crew, frequent air travelers, and long-distance drivers. Patients also on extended screen time are at risk for problems. And in this current pandemic, it will include practically each and every one of us. Now, patients with medical risk factors would be fifth, and this include medical conditions like collagen vascular diseases, ovarian dysfunctions, patients that had refractive surgery, and those on treatment like antihistamines, antidepressants, or chemotherapy. And contact lens users would also be in this group because in itself, the usage of contact lens is a risk factor for ocular surface disease. Now, for the second group would be patients on medical treatment that would benefit from switching. This will include patients that develop ocular surface disease from glaucoma medical treatment, those on multiple medications because of the increased risk of ocular surface disease due to a higher preservative exposure. And finally, your pre-surgical patients because of the poor outcome of trabeculectomy with prolonged exposure to the toxic effects of preservatives. Let me end by saying that the quantity of pressure control remains the cornerstone in glaucoma management. Reaching target pressure, considering the cornea in pressure evaluation, medications with good response rates, and minimal pressure fluctuation are all important factors. But only with patient comfort and satisfaction, together with adherence and persistence, can we reach quality pressure control that secures a better quality of life for our patient and an improved doctor-patient relationship. Thank you so much.
Those were comprehensive and interesting lectures from our first three speakers. As a glaucoma specialist, it was very interesting to see the animated effects of the preservatives we commonly see in most medications. I definitely learned a lot, and I hope our viewers did too. Speaking of viewers, I think we have a number of questions for them. Let us go through some of those in the next few minutes. May we invite the first three speakers back into the screen as we read these questions. Please feel free to answer them. Mike, would you please do the honor of reading our first question?
Okay, so for our first question, can we reverse the effects of BAK on the corneal epithelium, or is this damage permanent? Any of our speakers, please feel free to answer.
You can, as long as the epithelium has not been severely damaged. As you know, the epithelium can regrow, but once destroyed, the cell cannot regenerate. I mean, it cannot be repaired. So it can be replaced by further mitosis. The problem is, if the damage goes deep enough, it will destroy the actively dividing layers to the basal layer. Then you will severely disadvantage that cornea, that conjunctiva, and it will not regenerate as well.
So I guess we're talking about also trying to stop the vicious cycle that this toxicity will create as well. Dr. C, would you have any thoughts on this?
Yes, stopping the BAK, like in our toxic keratoconjunctivitis patients, when we see them, what we first do is stop the medication. And then we put the patient on non-preserved artificial tears, and then wait for the epithelium to, or for the damage to go away, or the epithelium to regenerate.
Thank you, Ellen. I think we see this a lot in our day-to-day patients, not to that extreme, but maybe small side effect of the back or preservatives that we see in our drops. But from a glaucoma point of view, let me ask Dr. Veloso. I think from Glau question would be, are preservative-free medications as good as, if not better than the preserved anti-glaucoma meds for IOP control?
Actually, Rainier, in most of the studies I came across, because they compared how effective the preservative-frees would be compared to the preserved medications, since preserved medications increase corneal permeability and that's increased drug penetration. So most of the studies I've came across, it's similar efficacy for both preserved and preservative-free glaucoma medications.
And of course, it will also go to compliance. If a patient gets all these OSD symptoms, then a patient may not apply the medications that he has for IOP control, right?
Yes, actually, that's a very good point. So aside from efficacy being similar, it's superior in safety and tolerability. So you're right there that if they're comfortable and happy with the medication, then adherence and persistence won't be a problem.
Okay, great. Good point, ma'am. For our next question. Which among the five mentioned BAK substitutes do you feel is the most viable option in terms of widespread replacement of BAK in generic formulation of ophthalmic solutions?
So of the five mentioned softer preservatives, I usually start most of my patients on either Polyquad, Purite, or Gen Aqua. So those are the three main preservatives, eye drops that have those preservatives that I use in my patients. I usually do not start them off with BAK preserved artificial tears. No, the Sofcia is not available here. The Diquas with the chlorhexidine is for special cases and not for all our dry eye patients.
Yeah. Can I say something? One of the problems in substituting alternatives to BAK is that not all of these alternative um, preservatives are actually stable with the other active ingredients. So it's actually chemically not possible to mix another type of preservative with certain types of active components. And that's the problem. You see, if that was possible, then they probably would have replaced BAK across the board. But BAK is a very stable solution, and it stays very keeps in solution very well, and that's why uh, they tend to. Of course, it's also very cheap, and that's why they stay with it a lot. No? Also, remember that the whole industry, most of the industry has already geared up to using it. So to shift gears and try to find something else will take a very big investment.
Yes, added to that, if you can see, most of the softer preservatives are exclusive to the drug to the pharmaceutical companies. No, so one pharmaceutical company cannot use the other preservative unless the patent has expired, or I think they buy the rights to the preservative from the other pharmaceutical company.
Okay, Rain. Do we have any other questions? Okay. So for softer preservatives still contain preservatives, in which situation would you use medications with alternative preservatives? When would you use preservative-free medication?
So as I've mentioned earlier, for my patients, for the alternate preservatives, I use them in my dry eye patients. But to start with the preservative-free medications, I usually give them for patients who need frequent dosing. So frequent dosing means more than 6 times a day. No, so that is my for preserved eye drops. No, more than 6 times a day is called frequent already. But it's not. You can also start with preservative-free eye drops right away. No, you just consider the cost and the ease of use of the vials. Sometimes our elderly patients cannot see the vial, have difficulty opening it and recapping it. So that's one of the factors. But actually, some of my patients who don't really use eye drops that often, they prefer the single dose vials because they are handy to put in their bag and then use when they need it. No?
One thing that you should consider when you prescribe these drops is how long do you intend them to use the drops. If you're going to prescribe them for dry eye or glaucoma, and we assume that it's supposed to be used for a long period of time or even lifelong use, then you have to try to steer away from those with preservatives. If you can give a preservative free from the outset, that would probably be best. Of course, if there are no substitutes, then you just have to tread that fine line, no? And be very aware and maybe monitor the ocular surface very well before any complications can be seen.
Sir, corollary to what you just said, we know that patients eventually get OSD either from the preservatives or from the molecule of the glaucoma drug in itself. So is it advisable then to always advise our glaucoma patients to have lubricants to minimize the effects of these molecules?
Well, yes and no. You can't really, the lubricants do help in protecting the epithelium to a certain extent. However, eventually, the BAK or whatever preservative you have will also cause damage already. And no amount of lubricant will protect that or revive the epithelium there. No? So in most cases, the role of the lubricant is merely to act like a liquid bandage, so to speak, on the surface, allowing the dry spot or the denuded area to try to grow back. So it's just like healing an abrasion. But if there's too much damage already, no amount of lubricant will help the surface. So what I'm saying is the glaucoma specialist should work with external disease or a cornea specialist in monitoring the surface. We have very nice tools nowadays, no, to detect dry eye and examine the surface, like the Oculus keratograph, no? And we have all these tools that we can diagnose much earlier if there's any risk, so that you, like for example, if you're intending to control the glaucoma, you might want to try a minimally invasive device instead of prolonging the medication. So I'm not saying that this is a perfect solution, but I think the minimum that we should do is to try to watch these patients more closely than we normally do.
Okay, thank you very much, sir. To our guest speaker, Dr. Veloso. So when we have a patient with OSD, do you automatically shift the patient to another anti-glaucoma medication, or do you give preservatives-free and try to see if the effects of the lubricants will somehow manage the OSD symptoms?
So the question, Rainer, is if the patient has OSD, do I right away shift already to a preservative-free if they're on a preserved medication?
Yes,
Is that
ma'am.
the question? So for
Yes.
me, as long as there's so as long as there is a preservative-free version, because not all of the glaucoma medications, as we know, no, have preservative-free versions, I would shift and I would try to use preservative-free lubrications also to help them. And in patients probably with multiple medications that don't have a preservative-free version for some of the medications that are on, it might be likely that we may have to consider selective laser trabeculoplasty, if it's an open-angle glaucoma case, to be able to at least decrease the number of medications the patient is on.
Ellen, would you like to say, do you have some
Yeah,
input on this?
because no, I saw a comment of Dr. Duwalan in the chat box of our YouTube channel. He said that about the antimicrobial activity of the self-preserved antibiotics. No, also I would like to emphasize it doesn't mean that the antibiotics mentioned there are effective against those microorganisms when you use them in infections of the eye of the patient. No, so regulatory companies in the U.S., Europe, and Japan have different what we call antimicrobial preservative efficacy tests, and those are the five. So the five main organisms are the ones that should be killed by the solution itself when the preservative is there, or if it doesn't have a preservative. But it doesn't mean that you can use it for those types of conditions in the eye. No? So we just like to emphasize that.
Right. So in other words, Ellen, what you're saying is do not use it for fungal infections. Do not use it for protozoan infections. Yes.
Yeah, it means that the preservative will kill all of those when they inadvertently contaminate the solution, the multiple dose bottle. But the solution itself, they have other indications. No? So look at the insert, see what types of organisms can be killed by those drugs. Like they're antibiotics, so obviously they only can work on bacteria. No? So do not use them for fungal infections, for other infections that are not in their indications.
Okay, so I think that's all the questions for now. One more.
Okay.
We have one
There's one more.
more.
Yeah.
So, how do you prepare an eye on chronic glaucoma medication treatment for trabeculectomy?
Okay. This is a good question. But I think to answer this question, it depends on the time you have before you have to really do the trabeculectomy. If you're talking about an advanced glaucoma patient that's controlled on full meds, and you want to do the surgery, of course, right away, and you probably only have a week, I don't think shifting to preservative-free will make much of a difference in this particular case. What I'd probably do if I don't have much time to prepare the eye, I'd probably treat with topical steroids. Anyway, it's just a short period before you're going to do your trabeculectomy. And what I'll probably do is I'll make sure there's an intraoperative subconjunctival steroid depot, and also modulate the post-operative steroids, giving it at a higher dose and for a longer period of time. Now, if it's another case where you are probably just checking whether an additional medication you've added will be able to bring you back to target pressure, but you're already preempting doing a filtering surgery, then in these cases, then shifting to preservative-free, switching to fixed combination. I'd probably also try to treat problems if there are like dry eyes or there's like a blepharitis, just to lessen the inflammation on the eye. And also do the same modulation post-op on the steroids, and give also an intraoperative subconjunctival depot.
Okay, thank you. Thank you. Rain, is there any other questions?
For Dr. Veloso, for
Okay.
patients on chronic glaucoma treatment with OSD, when will you consider filtering surgery?
Yeah, I'll really try my best to manage the patient conservatively. So it also depends on the level of ocular surface disease. If it's a mild dry eyes or mild blepharitis, which I encounter a lot, and the patients they always tell me they're comfortable. Well, I would give them the option of doing, as we mentioned earlier, selective laser trabeculoplasty. Of course, shifting, we make sure that, of course, we have shifted to preservative-free. And if the patient has medications we can combine again to fixed combination, I'll do that. But if it reaches a point that the patient cannot really tolerate it, even, and it's not controlled by laser, then there is a possibility that in the end, we may have to go for glaucoma surgery to lessen the load of any toxicity from medications.
Okay, thank you, Dr. Veloso.
Thank you.
Thank you. That ends all our questions for today. And of course, we'd like to thank all our speakers for generously elaborating each of the concepts. And so I hope we were able to enlighten you more on the focus on this episode. But to supplement our learning on the preservative-free treatment, we will be discussing some cases, case presentations and discussions after this short break. So please stay tuned.
Increasing IOP is a key risk factor in glaucoma progression. IOP fluctuates over the course of a day, with elevated levels at night. And IOP is still the only modifiable factor in glaucoma treatment. But is just a strong IOP reduction enough? Studies show greater IOP fluctuation may increase visual field progression. Quality-based IOP control may be more effective than just quantity-based reduction. Tefloprost. has the power to control IOP through day and night with a greater nighttime IOP reduction. Behold, Tafloprost brings you the power of quality IOP control.
Yes, we're back, and we'd like to thank our sponsor again, Santen, for graciously hosting our 12th episode. They have been a great partner for all of us ophthalmologists in treating various eye conditions ever since.
Okay, so now we'd like to move on to the case presentations. We have invited two budding ophthalmologists to share some of their previous experiences in managing patients with OSD and chronic glaucoma. Rain, would you like to introduce our first
Sure,
speaker?
no problem. Our first presenter is Dr. Renato Rayel. Jet, as he's commonly called, graduated at Ateneo School of Medicine and Public Health. He then trained in ophthalmology and glaucoma at the Philippine General Hospital, Department of Ophthalmology and Visual Sciences. He is currently based in Davao City and is a practicing glaucoma specialist at Davao Doctors Hospital and at the Southern Philippines Medical Center. He is also part of the PAO Research Committee and just recently inducted into the Philippine Glaucoma Society.
Now, for our second case, we have once again Dr. Tina Tan. Tina is also a graduate of the Ateneo School of Medicine and Public Health. She finished her residency in the Medical City Eye and Vision Institute, where she's currently doing her fellowship training for cornea external disease and refractive surgery. So let's proceed.
So, good evening, everyone. I would like to thank Santen and the Medical City for this invitation. It is definitely an honor to share the screen with my beloved professors. The value of preservative-free medications is something that I picked up during fellowship. It is a small decision to write the words preservative-free on the prescription, but it is something that can improve your patient's quality of life and provide you with peace of mind. So, without further delay, allow me to present case 1. This case involves the use of preservative-free medications as first-line glaucoma therapy. Our patient is a 46-year-old male who had a 1-year history of intermittent bitemporal headaches that were occasionally relieved by pain medications. He had no ocular symptoms such as eye pain, blurred vision, redness, or otherwise. Due to the intermittent nature of his symptoms, he never sought consult. He attributed his symptoms to his spectacle use as it had been 2 years since he was last refracted. Eventually, he decided to consult with an eye doctor. His ophthalmologist noted borderline elevated IOPs and cupping in both eyes. His ophthalmologist wasn't sure whether to treat this as a case of physiologic cupping with borderline IOP or as an outright case of glaucoma, hence referral for evaluation and management. Physical examination showed good distance visual acuity in both eyes, with only slightly elevated intraocular pressures. Gonioscopy was done, which revealed open angles in all quadrants. Disc examination showed enlarged cups with CD ratio of approximately 0.8. Apart from the generalized cupping, there is some notching of the inferior neuroretinal rim on the left eye. When using a red-free filter, there were suspicious RNFL defects inferiorly in the right eye and larger wedge defects in the left eye. I hope that you can see this on your screens as it is a little difficult to take red-free filter photos on the slit lamp. So to recap, we are presented with a middle-aged male with slightly elevated pressures and open angles. The structural optic nerve changes were likely indicative of glaucomatous damage. As such, I labeled the case as a POAG patient. I ordered a glaucoma package including a central corneal thickness test. Both PGAs and SLT were viable options for this patient. At the time, the results of the light trial had just come out, and I wanted to discuss this with my patient. I waited for the results of the laboratory tests to confirm my diagnosis before fully committing to my planned intervention. Looking at the OCT, we see moderate cupping in large discs. The amount of cupping is not definitive evidence of glaucoma in this case because of the size of the optic nerve. What is more important to note in this case is the amount of sectoral RNFL thinning, particularly in the left eye. CCT, an important predictor of progression, showed thin corneas, which means that IOP is in fact being underestimated in this patient. This can explain the amount of structural damage we're seeing despite getting borderline pressures on follow-up. Humphrey perimetry done showed good reliability with corresponding visual field defects. The right eye shown here on the right side of the screen has a small but moderately deep scotoma in the superotemporal area. The left eye showed moderate generalized field depression, a structurally well-correlated incomplete superior arcuate scotoma, and a paracentral scotoma. The presence of a 0 decibel reading within the central 10-degree field qualifies the left eye as a severe visual field defect, although this was only the first perimetry test. A 10-2 should be performed on subsequent testing for the left eye. Given the results of the tests, the working theory is that this is an ocular hypertensive patient who progressed to primary open-angle glaucoma. Looking at relevant risk factors for progression, we can actually determine that this patient had a very high risk for developing POAG. His risk stratification warrants intervention. The patient was started on preservative-free tafloprost. The initial target IOP was set at 15 millimeters mercury based on a desired 30% reduction from a baseline of 22. We were able to achieve the desired intraocular pressures. This patient is due for follow-up testing. Unfortunately, due to the lockdown of Davao City due to COVID-19, he was unable to get his tests. Case number 2 involves the use of preservative-free medications to optimize filtering surgery outcomes. Our patient is an 80-year-old diabetic male who was being managed for chronic glaucoma. 10 years prior to consult, he noted gradual progressive blurring of vision in both eyes, which did not improve despite cataract surgery. At the time, he was being managed by a doctor outside Davao City. When he moved to Davao, his new ophthalmologist referred him for further management. At the time of consult, he was on 1 fixed combination medication on the right eye and 2 fixed combination medications for his left eye. Both eyes were maintained on artificial tears, which relieved the occasional ocular discomfort. Physical examination showed vision of 20/60 on the right and 20/70 on the left. Intraocular pressures were 14 and 27. The left eye showed significantly more hyperemia than the right. His refraction revealed pseudophakic monovision with the poorer eye being targeted for near. This, of course, isn't ideal in advanced glaucoma cases. This is because permanent visual defects can prevent one or both eyes from functioning independently at an adequate level to support monovision. Fortunately, he already had some diagnostics done. His OCT revealed severe cupping in average-sized discs with sectoral RNFL thinning. Macular ganglion cell complex scan shows a generally thinned out GCC layer in both eyes, falling below the first percentile compared to the normative database. Octopus perimetry with G-program test using a dynamic strategy showed moderate field depression with superior arcuate and central ficocentral scotomas in the right eye. The left eye showed severe generalized field defect with which was more pronounced superiorly if we look at the raw data. This correlates well with the inferior RNFL thinning seen on OCT. Central paracentral scotomas are also seen. Examination of the central 10 degrees shows threatened fixation in both eyes. Assessment for this case was advanced primary open-angle glaucoma due to the bilateral presentation of disease, open angles, current intraocular pressures despite medical therapy, as well as structural and functional evidence of advanced optic nerve damage. I advised the patient regarding his options, including the importance of doing a trabeculectomy. However, the patient opted to try SLT first. He was later shifted to preservative-free medications. This is the right eye. The first picture is on regular fixed dose combination bimatoprost plus timolol. The second picture was taken 4 months after the patient was shifted to preservative-free tafloprost with timolol. We can note that there is decreased hyperemia. This is likely from a combination of switching the patient from a molecule that is known to cause more hyperemia and from decreasing the overall preservative load. This is the left eye. The photo on the top right was the patient on the first visit. Here we see a hyperemic conjunctiva. This is the type of eye that you know will have a tendency to bleed when you do trabeculectomy. The photo on the bottom left was taken preoperatively 4 months after the patient had been shifted to preservative-free medications. The photo on the bottom right was taken 3 months following surgery, showing a diffuse, low-rise, relatively healthy-looking bleb after sutures have been released. To summarize, I presented 2 cases where preservative-free medications played an important role in the management of glaucoma. The first case was a young, treatment-naive ocular hypertensive who progressed to open-angle glaucoma. The use of preservative-free tafloprost allowed me to achieve my target IOP for the patient. The second was an open-angle glaucoma patient on chronic glaucoma medication use. Shifting his medications to a preservative-free formulation allowed me to optimize the appearance of the conjunctiva in preparation for surgery and likely contributed to the patient's successful outcome. There are other indications for the use of preservative-free glaucoma medications. Glaucoma patients who are at risk for developing ocular surface disease or already have pre-existing ocular surface disease can also benefit from these medications. There are many other indications, as Dr. Veloso pointed out in her lecture. To end, I would like to stress that glaucoma entails a holistic approach. We must continually assess risk factors for progression, such as our ability to control underlying etiologies of the glaucoma, management of angle mechanisms, and the patient's compliance to follow-up and therapy. We must always keep track of the stage of glaucoma, and we must ensure that the patient's quality of life is maintained. If we look at the development of glaucoma medications, we started with individual drugs. By combining these into fixed combination doses, we were able to address issues with compliance. As we wait for new glaucoma drugs and devices to come out, improving our current armamentarium is the next logical step. Preservative-free medications will allow us to treat IOP, decrease adverse effects, improve compliance, and improve the patient's quality of life. Thank you.
Okay, so good evening, everyone. I will be presenting a case consult for a patient seen at our OPD. So this will be an open discussion in terms of management, and it's open for comment for our glaucoma and cornea panel. So our patient is LDR, a 72-year-old female. The patient is retired and living with her husband, who also is diagnosed with glaucoma. They both depend on their son for finances and follow-ups, and the son also has glaucoma, and the patient has difficulty commuting for her follow-ups. The patient's drug compliance is also very stable, actually depending on her son's financial capabilities. So she relies heavily on sample medications provided at the OPD. She often switches from medications depending on the availability. So most of the time, she can't afford to buy her own anti-glaucoma medications. And she is also hypertensive and maintained on losartan. So the patient was referred to us by our glaucoma service. Currently, her IOPs are stable. but she has been experiencing increasing eye discomfort with foreign body sensation and redness for both eyes. So the patient already had these symptoms before, but noted a worsening of her symptoms within this year. So the patient had a very, very prolonged course of glaucoma, which was first managed at her OPD around 7 years ago. So for ease of this discussion, I'll subdivide the patient's history into two parts. So first would be the glaucoma history, and the second would be the ocular surface disease, which are the major problems identified in this patient. So the patient was seen at our OPD 7 years ago for second opinion for blurring of vision. She was previously seen at another institution and was diagnosed as a case of primary angle closure glaucoma, both eyes, where YAG-LI was performed. On initial examination, IOP was 19 and 20 millimeters mercury. Gonya showed closed angles with multiple scattered PAS in all quadrants. On fundoscopy, glaucomatous-looking cups at 0.9 with normal-sized discs was seen in both eyes. So the PFT revealed severely advanced damage with double arcuate scotomas in both eyes. And since the cataracts were present, the patient underwent phaco with goniosyncytialysis and AC deepening of both eyes. So the patient's pressures were controlled in the low teens, which was our target IOP for this patient during the interim, until several months after, where the pressure increased to the 30s in both eyes. So she was given Lumigan once at bedtime and Alphagan thrice a day, but the pressures were still uncontrolled with these medications. So trabeculectomy with mitomycin C was performed on both eyes to help reach our target IOP. So during the interim, the pressures were controlled to the low teens again. However, after more than a year, the IOPs again increased to the 30s for both eyes. And the patient was then shifted to Duotrav once at bedtime and Alphagan thrice a day. The pressures were still uncontrolled with these medications, so bleb needling with 5-FU was performed twice for both eyes. Pressures were controlled in the left eye after the needling, but pressures on the right remain uncontrolled. A repeat trab with mitomycin C was done on the right eye to maintain the target IOP. Next slide. So during the interim, pressures again were in the 20s, which was above our target IOP of low teens. So medications were shifted to Simbrinza twice a day for the right and Astimol once at bedtime for the left eye. So pressures were currently controlled at the low teens for both eyes with this regimen. So it's just important to note that this patient has had a chronic history and use of IOP-lowering medications for the past 7 years with poor compliance due to the lack of funds. The patient also heavily relies on available sample medications, so she just usually uses the meds that are available at our OPD. So it's important to note that there was no pre-existing OSD present when the patient was initially seen at our OPD. So after starting the glaucoma therapy, the patient began to develop mild inferior SPKs in both eyes with dry eye syndrome. The patient was then given cysteine eye drops 4 to 6 times a day as maintenance, and the patient's ocular surface worsened during the interim. So in 2017, the patient developed an epithelial defect in the left eye, where she was given Vigamox 4 times a day, Hyabac 4 to 6 times a day, and Lacrovisc eye gel once at bedtime. A superficial keratectomy was also performed with no recurrence of this defect. So during the interim, the SPKs in dry eye progressively worsened and the patient was diagnosed as a case of toxic keratoconjunctivitis for both eyes with consistently low tear breakup times. So preservative-free Hyabac was added every 2 hours and Lacrovisc eye gel 3 times a day. So for the ocular examination, visual acuity uncorrected was 2200 minus 1 for the right with no improvement on pinhole, and for the left 2160 plus 2 uncorrected with improvement to 2125 on pinhole. Near vision is J16 for both eyes, and grossly no matting, no tearing, discharge swelling, or erythema. The other findings are also unremarkable. So applanation tonometry showed us stable IOPs at 7 and 10 millimeters mercury. The gonioscopy revealed open angles up to the trabecular meshwork with scattered PAS in all quadrants for both eyes, and fundoscopy showed a cup disc ratio of 0.9 to 1 with pale nerves. So this is the latest visual field test of our patient, which shows severe glaucomatous damage in both eyes with central islands of vision remaining. So the mean deviation for the right is 25.21 decibels on the right and 29.14 decibels on the left. So on slit lamp examination, of the right eye, the cornea is hazy with limbal neovascularization, with the presence of diffuse superficial punctate keratopathy with an irregular corneal surface. There are also iris pigments on the endothelium. The IOL is in place, and the bleb is flat and vascularized. So for the left eye, there's also the presence of diffuse SPKs. The IOL is in place, and the bleb is cystic. So here we have the examination of the lid margins. As you can see in the pictures, it shows plugged meibomian glands with lid telangiectasia and hyperemia. So if you also see closely, the lid margins also have irregularities and lid notching with thickening. And meibomian gland grading for this patient is A2, B3 for both eyes, with toothpaste-like secretion and no glands expressed. Next slide. So we also performed tests for dry eye at the dry eye clinic. So as you can see here, the patient's OSDI score was at 40, showing moderate severity of symptoms. The tear meniscus height is slightly reduced at 0.17 and 0.16 millimeters. Our nick butt is very short at 0 seconds on the right and 2.48 seconds on the left. And you have the Schirmer's test, which is moderately reduced at 6 millimeters for the right eye and 12 millimeters on the left. Unfortunately, since the patient had a lack of funds, osmolarity tests were not done. So here we can see moderate redness around the limbal and bulbar areas for both eyes. And this is a video for both eyes. As you can see here, lipid interferometry will show a very, very pale whitish hue of the lipid layer in both eyes, which means that there is a significant lipid deficit. So now we see the meibography. So this revealed more than 67% dropout of glands in both eyes. So here we have the TFOD. So if you play the video, the upward movement of fluorescein is not really observed for both eyes within the lower part of the cornea. And for the TFOD, it shows you an atypical area break for both eyes. You can also see grade 3 corneal staining on the right eye and grade 2 corneal staining on the left eye. So this indicates the patient has very severe OSD. So based on the tests performed, we diagnosed the patient as a case of toxic keratoconjunctivitis secondary to IOP-lowering medications for both eyes. So the TFOD shows an atypical area break, which indicates severe aqueous deficiency for both eyes. There is also meibomian gland dysfunction bilaterally with punctate keratopathy both eyes. So the plan for this patient is twofold. So our primary goal for this patient would be to manage the patient's glaucoma. So we have to be able to achieve an IOP control with the least number of drops without preservatives in order to preserve the visual function of the patient and prevent further decline. And this in turn prevents further damage from the ocular surface disease. And the second goal would be to optimize the ocular surface to preserve the tear film stability, improve inflammation, visual function, and also to improve patient compliance. So we'll first review the patient's current medications. Again, as I have mentioned earlier, she is currently on Simbrinza twice a day on the right eye and Astimol once at bedtime for both eyes. So glaucoma-wise, she is on 4 classes of IOP-lowering medication to control her pressures. She is also on preservative-free Hayabac every 2 hours and Lacrovisc eye gel 3 times a day. So looking at these medications, you can see that 3 out of the 4 contain the preservative BAK. So as we heard from Dr. Capras's lecture, BAK is harmful to the ocular surface in many ways. So it has a detergent effect that disrupts the corneal epithelial cell membranes, causing damage to the surface. It also disrupts your lipid layer of the tear film, which increases your conjunctival inflammatory cells and increases your tear breakup time. So the effect of BAK, as Dr. Capres mentioned, is also cumulative. So in this patient, we can see why she developed toxic keratoconjunctivitis from prolonged topical treatment. So since I'm not a glaucoma expert, I'd like to ask the opinion of our glaucoma panel and open the management of glaucoma up for discussion. So this will be for Dr. Escobar, Dr. Veloso, and Dr. Real. So the patient's IOPs are currently controlled, but with a concomitant ocular surface disease that is worsening. So our primary goal, again, would be to use the least amount of IOP-lowering medications to prevent further toxicity to the ocular surface. So doctors, I'd like to ask, would you start to reduce or remove either the Simbrinza or Astimol and monitor if the IOP is still controlled for this patient? Or would you already shift the medications to preservative-free options since there is already very severe ocular surface disease damage? So here I placed a table of the available options for preservative-free and alternative preservatives of IOP-lowering meds currently available in the market. So since cost is also an issue for this patient, I also included cost per year with a senior's discount just to see how much the patient would be spending per year on maintenance. So doctors, again, aside from the medical options, like I know Dr. Veloso already mentioned it, would surgical options still be appropriate for this patient? So can we do laser procedures such as SLT and partial micropulse diode lasers to help control the pressures? I've recently read in some studies that SLT results are not very consistent. Some studies have reported success in lowering the pressures in post-trab patients, but other studies say that there is no improvement in lowering the IOP. So also, I have also read that SLT may be very temporary, so you might have to repeat these lasers once the effect wanes out. And also, could we consider partial diode micropulse in this case to help decrease aqueous production and lower the IOP? And lastly, would you consider doing either a MIGS, particularly an eye stent, or a GDD in this patient? Do you think it would still be a possible option if the patient already had a repeat trabeculectomy in the right eye and a trabeculectomy on the left eye? So this is my last slide. We will move on to the management of the ocular surface disease, which is the patient's current complaint. So our treatment would be twofold in this case. So first is to manage the aqueous deficiency, and the second is to treat your meibomian gland dysfunction. So for aqueous deficiency, we can start by giving the patient a P2Y2 receptor like diquafosol sodium or DQuas 6 times a day. So this acts on the conjunctival epithelial and the goblet cells to secrete water and mucin, both of which the patient doesn't really have. It is also important to note, however, that DQuas also uses a preservative chlorhexidine, as mentioned in Dr. Assis' lecture. And this can still cause some toxicity to the ocular surface, so we should still be using this with caution. So I know that there will be a preservative-free version of DQuas in the future. It will be called DQuas S. So this should be a future option once it becomes available. So preservative-free lubricants like Hyabac, which the patient is currently using now, can be maintained every 2 to 3 hours. We currently, unfortunately, don't have an eye gel that is preservative-free at the moment, so we should also be using this with caution in this patient. We can also opt to use punctal plugs to increase the tear volume, preferably the absorbable ones. But again, the use of these punctal plugs should be used with caution because this can cause a buildup of inflammatory cells within the ocular surface and also the preservatives. So we should also treat inflammation for this case because, again, as Dr. Veloso mentioned, PAK can cause a buildup of the inflammatory cells in the epithelium and conjunctiva and the ocular surface, and it can cause fibrosis and later failure of your filtering surgeries. So we can start the patient on Icurvis, which is preservative-free 4 times a day to control the inflammation. And lastly, we should treat the MGD by asking the patient to do lid hygiene and warm compress. We can also have her start with omega-3 capsules, but again, this would add to her expenses. And since her meibomian glands are plugged, we can do a microblepharoexfoliation with a Blefex instrument. And lastly, we can opt to do an IPL with low-level light therapy to help make the meibum less viscous and help unclog the plug glands. Next slide. So this is the end of my presentation. Thank you very much.
Thank you, Jet and Tina, for those interesting cases. Let us welcome back on screen our first three speakers to give their comments on the cases.
Okay, in the interest of time, we're already over time. We cannot compromise more questions for now. So we'll just listen to the discussion of our experts and they will surely cover most of our queries, okay? So Rain, maybe we should start with a question.
So, Tina, in your case that you presented, you had an interesting case wherein you presented an elderly patient with both glaucoma and OSD, right?
Yes, sir.
And the patient is a post trabeculectomy in both eyes, but still with controlled pressures on the left, but was already on full medications
Yes, sir.
on or anti-glau meds, right? So let me first throw this question to our glaucoma consultants here, Ma'am Marimel and Jet. In this situation, we're in, we have a patient with OSD on full medications, post trabeculectomy, obviously, which has failed. What are the options that we may offer this patient aside from pushing her to maintain on medication?
Yeah. Tina, the patient is in advanced stage. So I think I remember you showed the visual field, point
Yes, yes,
0.9.
Dr.
Yeah,
It's already
2.9.
0.91.
But as you said, the pressures with the two medications, the fixed combinations, the two fixed combinations covering four classes, are within less than 10. Is that correct?
Yes, yes, Doctor. It's
How,
7
how
and
long
10.
is how long has it been that way on those medications? Is it like
For these
weeks or months or
combinations, no, Doctor. The several months na on these
several months?
medications.
And your field, how does the fields look like when you repeated it to see if they're stable? It's just because if you're on meds, sometimes when you take the pressure, we think they're controlled, but they fluctuate. But if they just miss it, or let's say naubusan, yeah. So I just want to know if you were able to do like a repeat field testing to
Un-
compare whether on the current medications, how good is the stability first of the visual field? Were you
so,
able?
unfortunately, ma'am, that was the last visual field test that we were able to do. Due to this pandemic, the patient is not able to follow up yet at the OPD. But that's one of the things that we will be doing once she follows up.
I'm more inclined to go for glaucoma drainage device already because it's an advanced case. Yeah, and the field really looks bad. And at least with surgery, the pressures are more stable. Even though wala siyang gamot or she misses it, yeah, you know that you're more or less controlled if she depends a lot on samples. And
Mhm.
so that's my take on this. No, now you were saying that SLT. The problem with SLT, the pressures are already very low. No, so usually in SLT kasi it works more when your pressure baseline is a little higher than less than 10, yeah. So you're right there, it might not be a good option. So in my opinion, I would go for a glaucoma drainage device already.
Doctor, I
Jet?
just have a question
Yeah.
regarding the glaucoma drainage device. Since the patient's superior conjunctiva is already fibrosed at this point, would you choose another site to place the drainage device in?
Actually, Tina, that's the advantage of the glaucoma drainage device. Even though it's scarred, we're still able to put in like a tube with a, and it works well. And that's one of the indications of the tubes anyway. So I think we will still go for the superotemporal, even though like there's a previous tab there. If ever there's a problem with the sclera, let's say a trab was done in that superotemporal area, which is our first choice, we can always use a graft. To cover the tube. So it will still be possible to do it in the superotemporal site.
Jet, do you have anything to add to what Ma'am Marimel just said?
Yes po, I agree po with the glaucoma drainage device po, given the advanced nature of the case and the patient's already on several medications. With regards to treating the dry eye, since while we're waiting to do GDD, yes, we can shift the patient to a preservative-free formulation just so we can maintain the number of medications and the pressure of the patient while waiting for surgery, and at the same time decrease the preservative load of the patient.
So that's a good point, Jet. Ano? We can replace some of the patient's medications with the preservative-free fixed combination medication just to reduce the load of the preservatives in the patient's eye, at the same time decreasing the inflammatory reaction which can happen even after the surgery. Like what Dr. Capara said, using anti-glaucoma medications carry substantial costs for the patient. And sometimes surgery can actually, in the long run, be less expensive than putting all these glaucoma medications lifelong. So especially now with the GDDs, the Philippine Glaucoma Foundation actually can help indigent patients or some of our patients who cannot afford these GDDs, so that the cost actually will not be that much for them. But aside from the glaucoma management, we also have to look at the OSD problem that this patient has, right? You've mentioned already some of the treatments or management that you have done for this patient. I'm sure our chairman, Dr. Vic, would like to add something and actually can expand on some of the things that we do at Medical City, like the IPL, the machines that we have at the LASIK Center. Sir?
Well, yep, sure. One of the things I can add is we should consider using autologous serum for this patient. It's going to be much cheaper, and it has several advantages. It has an anti-inflammatory effect. It will have the necessary mucins and growth factors that will help regenerate the epithelium. It's in our institution, it's very inexpensive to make. And I think Doc Mike, we've used it several times. And it has worked. No? So that's one of the things that when she comes back, we should discuss with her. The MGD is also has to be treated because if we cannot revive the lipid layer of the tear film, then this patient will always have a dry eye and the OSD will not get better. To comment on the use of certain of the medications being used now, while DQAS will result in increased mucin secretion, with OSD this advanced, I'm not so sure if any of the goblet cells there are viable that can cause increased mucin secretion. Also, I noticed that you're using Lacrivisc, which has a preservative called cetiramide, and which can be just as deleterious to the epithelium as BAK. So I think we really need to review everything here that we're doing on this patient and try to basically reduce all the toxic elements in that regimen. Finally, just to comment on Dr. Rael's cases, this is exactly, and I congratulate him for the two cases and the way he managed it. It's exactly what I was driving at when when you're aware of the possible problems and you act accordingly, you're able to avoid complications, such as the one in Tina's case.
Thank you, Dr. Caparas. I'd like to ask also, you mentioned the carbomer as having a preservative. Is it, I'd like to ask you and Ellen, is it an option? Maybe Ellen mentioned the hydrogel as having a commode type of mode of transport. Would that be an option to change for the carbomer?
I'm not so sure if hydrogel acts like the gel of the Lacrivisc. No? I think it's more like a viscous eye drop. So I'm not so sure that the contact time on the eye will be as good as a gel like Lacrivisc.
To Dr. C, some institutions might not have the ability to prepare autologous blood for as a supplement. And in your experience, what are the commercially available lubricants that can help this patient?
So all the preservative-free eye drops available in the market right now can help our patient in the interim. No, but I think still decreasing the load of the BAK is still from the anti-glaucoma medications, not just the BAK, but also the active ingredient would be the best solution for this patient. No, if we don't do that initially, then the OSD will just continue and we might not be able to treat it properly.
Mayor,
Yes,
Mike,
ma'am.
can I just ask you, Dr. Caparas and Dr. C, I just have kasi some patients with chronic medications nowadays. They're actually controlled, but there's a mild to moderate amount of ocular surface disease that they want to tolerate because they don't want to go for any surgery. So I'm giving them preservative-free medications for tears. No, I was just wondering your comment on topical cyclosporin. Do you think it would help, even though the inciting agent, of course, is still there because they're still putting the medication and just bearing with the ocular surface disease problem?
I'm not so sure that cyclosporin would be appropriate for most of these preservative-caused OST. Remember that cyclosporin, although it's an anti-inflammatory, it's effective against cell-mediated type of inflammation, cell-mediated type of hypersensitivity, so like T cell. No? So I'm not so sure that it can work in depressing the inflammation, which is caused by the toxic effects of
Medications.
a yeah. I would probably put these patients on maybe very short term, like pulse steroid for a while. And I don't know if it's acceptable to glaucoma experts to do like a drug holiday, maybe stay off it for several weeks. I don't know if that will work for you. But actually, our choices are very limited in trying to reduce the inflammation. Now, the reason why I mentioned autologous serum is because it does have a level of anti-inflammatory activity. And it has no preservative, obviously. It's the components of the patient's own serum. And it's a misconception that only advanced medical centers have it. If your hospital or institution has a working laboratory, you can make autologous serum. All you need is a centrifuge. Okay, yeah, and be able to do it in a sterile manner. But so I would probably try autologous serum for these patients that are having OSD, and obviously you can't keep the steroids there for a long time.
Thank you, Doc.
So to Mama Rimel and Jet, corollary to what Dr. Caparas just said, will you add steroid if this patient will undergo a GDD? Will you start topical steroid on this patient a few days prior to the surgery to maybe help decrease the inflammation that the surgery will bring?
Actually, if it's 2 weeks or less, no problem on topical steroids before the GDD. If it's longer lang kasi that's when the problem can come in for another steroid-induced coma to complicate the situation. Jeff?
Yes po, I agree po. Maybe we can also choose some of the milder steroids just to avoid any possible IOP increase related to steroid use.
Yeah, that would be
And
good.
just- Yes, and just like what we do now, we try to prolong the use of the steroid in cases where the inflammation is high in the conjunctiva, just so to make sure that the scarring at the Tino's level is not that much.
Although all our steroids have BAK, remember that. No?
Right.
2 steps forward and 1 step back.
Two-edged sword, no?
Yeah, so it's a catch-22. So, to excellent discussion from our panelists. Do you have anything else to add to this case? Excellent. So, if none, I'd like to thank our panelists, Dr. Caparas, Dr. Veloso, Dr. Ellen, plus Dr. Jet and Dr. Tina for the interesting discussion. This has been such a great learning and hosting opportunity, and I would like to thank TMC EyeTV once again for inviting Mike and myself.
Yes, thank you very much. It has been a fun experience. As you can see, our numbers of subscribers have been growing. So thank you to all our viewers for staying with us since the beginning. And as always, don't forget to click the thumbs up, subscribe, and hit the bell icon below to get notified whenever we release a new video from our YouTube channel.
A big
So,
thank you once again to Santen for partnering with us in this episode. And of course, many thanks to our speakers, Dr. Caparas for this brilliant idea of the ITV, LNC, and Marimel Veloso, as well as our case presenters, Dr. Jet Rayal and Tina Tan, for allotting some of their time and sharing their expertise with us. Finally, we would also like to express our gratitude to all our attendees for joining us today. TMC ITV wouldn't be this successful without your continued support. Once again, I am Rainier Victor Covar.
and I am Victor Michael Munoz
See you all again in the next episode of
of
a
the
victorious
episode.
episode of TMC ITV. Islamic Instruction Without Borders.
Then